Welcome to chronic kidney disease. When I say chronic, I mean chronic, like a long time ago. I don't think you understand. I'm talking Jurassic, or in this scene, actually, Jurassic. And it's not just uremia we'll be encountering, but all the all the clinical signs and symptoms of chronic kidney disease. Okay, first things first. What is chronic kidney disease? No, like I know you know what it is, but what is it really? For that, let's head to the coffee machine. It's out of order, unfortunately, but it's still the perfect metaphor for chronic kidney disease. Chronic kidney disease is actually defined as either decreased kidney function or objective signs of kidney damage, which has been sustained for at least 3 months. We use the estimated glomerular filtration rate, or eGFR, to assess renal function. Reduced function is defined as a GFR of less than 60 mils per minute per 1.73 meters squared. Now, objective signs of kidney damage, on the other hand, include albuminuria, urinary sediment abnormalities, imaging abnormalities, or pathologic abnormalities, things like glomerular disease, tubulointerstitial disease, and transplant rejection. We'll get back to albuminuria in just a little bit, so hold on to your butts. First, let's go over the clinical presentation of CKD. Early on, most patients are going to be asymptomatic, with only isolated lab abnormalities. Just like our happy-go-lucky paleontologist up here, giving the thumbs up. He's footloose and symptom-free. I don't mean to burst his bubble, but as CKD progresses, symptoms are going to start to show up. For starters, CKD can cause hypervolemia from impaired homeostasis of salt and water. This can manifest as peripheral edema, symbolized by this clumsy guy's edematous pants. And that exasperated breath represents shortness of breath from pulmonary edema. Salt and volume balance is actually pretty well maintained as long as the GFR stays above 10 to 15. Even with mild CKD, though, excessive intake of salt can lead to episodes of volume overload. Once CKD progresses to the stage of near ESRD, in other words, eGFR of less than 15, signs and symptoms of uremia will start to develop. These have been faithfully recreated inside this Jurassic display. Symptoms include fatigue, nausea, vomiting, and itching. Uremia is also associated with encephalopathy, as depicted by this encephalosaurus. Signs of encephalopathy include lethargy and confusion. The end game here is things like seizures, coma, and even death. Uremia can also cause a mono or a polyneuropathy. Mononeuropathies include things like carpal tunnel syndrome. The classic uremic polyneuropathy presents with distal lower extremity paresthesias and will eventually progress to burning pain. Uremic pericarditis is depicted by the inflamed casing of these heart-shaped eggs. The classic symptoms include pleuritic chest pain that gets worse when you lay down and gets worse with deep inspiration. Uremia itself can cause platelets to be dysfunctional, as highlighted by these broken stegosaurus plates. Patients might describe things like easy bruising, mucosal bleeding, and bleeding from the GI, GU, or the respiratory tract. Phosphate retention in the setting of CKD will lead to hypocalcemia. This is due to the binding of calcium in the serum. Decreased vitamin D production in the kidney will also contribute to this hypocalcemia. This combo of high phosphate and low calcium then can cause a secondary hyperparathyroidism. This promotes increased bone resorption. Say hello to the CKD, mineral, and bone disorders: osteitis fibrosis cystica, osteomalacia, and adynamic bone disease. These patients can present with pain from non-traumatic fractures, which are usually vertebral. We didn't come here to look at fossils. We came here to buy small collectible fossil figurines. Let's take a little break and head into the history store, where we can browse through your patient's past medical history, looking, of course, for the underlying etiology of CKD. So what's the most common cause of CKD in the United States? The answer is diabetic kidney disease, which you will learn all about over in our endocrine unit. If your patient has diabetes, try to get a picture of how well controlled their diabetes has been. A hemoglobin A1C can help. Keep in mind that the progression of diabetic kidney disease is directly related to the adequacy of blood pressure and glycemic control. Speaking of blood pressure, chronic hypertension is the second most common cause of CKD. Just look at that steam. Now, over time, elevated blood pressure is going to damage your renal arterioles, resulting in intimal thickening, luminal narrowing, and sclerosis. Okay, another cause of CKD is bilateral renal artery stenosis, depicted here by the stenosed red straps attached to those kidney-shaped purses. Stenosis of the renal arteries reduces the GFR and causes chronic ischemia. Now, this bilateral renal artery stenosis is most commonly caused by atherosclerosis. So it's important to assess for risk factors and get a history of vascular disease, things like peripheral arterial disease, stroke, and coronary artery disease. In fact, that coronary crown of hers with the golden center kind of looks like a clogged coronary artery, don't you think? We've made her muscular as well to remind you of fibromuscular dysplasia. This is a much less common cause of bilateral stenosis. Primarily, it affects adult women as well as young boys and girls. This non-atherosclerotic disorder causes stenosis and tortuosity of the renal arteries. Aside from renal disease, it's associated with arterial dissections and aneurysms in various arterial beds. Cerebrovascular involvement is really common, especially in women, which presents as things like headache, pulsatile tinnitus, and neck pain. Bendy straws. Not only are they super fun, they're a recurring symbol for glomerular diseases, which are decidedly less fun. Even a transient acute episode of glomerulonephritis in the past, as with post-drug glomerulonephritis, for example, increases the risk for development of CKD in the future. Chronic glomerulonephritis, seen in the setting of autoimmune diseases like lupus, chronic infections like hepatitis or HIV, as well as a wide variety of immune complex and vasculitis syndromes, will invariably result in CKD. For a more in-depth discussion of our glomerulonephritis syndromes, head on over to our Great Nephritic Wall of China sketch for more information. And you know what? Let's not give glomerulonephritis all the credit. Some causes of nephrotic syndrome can also cause chronic kidney disease, diabetic nephropathy for starters. But we're also going to highlight amyloidosis. At Sketchy, we symbolize amyloidosis with an armored lady, and in this scene, it's an armored purse. Let those chain links remind you of glomerular amyloid deposits collecting in the kidney. AA amyloidosis occurs in the setting of malignancy and chronic inflammatory conditions. In AL amyloidosis, the fibrils are made of light chains and can be associated with the monoclonal gammopathies. Speaking of gammopathies, the monoclonal gammopathy syndromes, such as multiple myeloma, are associated with a whole range of kidney disorders which can present as acute or chronic kidney disease, including AL amyloidosis, light chain deposition disease, and light chain cast nephropathy. In fact, 20 to 50% of patients will either have acute or chronic kidney disease at the time of diagnosis. At Sketchy, we symbolize multiple myeloma with a lytic spinal quiver, representing the classic lytic bone lesions and immunoglobulinemia that characterize multiple myeloma. The crab on his shirt should also remind you of the classic crab symptoms that go along with multiple myeloma, including hypercalcemia, renal failure, anemia, and bone lesions. Check out our Hem-Onc unit for all the leaky details, and for an in-depth look at what made the Middle Ages so frothy. As with chronic glomerular diseases, chronic interstitial nephritis can also cause CKD, represented here by this flaming hot kidney-shaped cup of coffee, that flame evoking an image of chronic interstitial inflammation. This can occur in patients who continue taking medications that cause interstitial nephritis, so get that medication history. Look for antibiotics or NSAIDs, for example, though the list of drugs that are associated with interstitial nephritis is long. Notice the inflammation extinguisher in the back there, highlighting NSAIDs specifically. Other possible causes of interstitial nephritis include some systemic infections as well as some autoimmune diseases like systemic lupus erythematosus, although these are less common. Be sure to check out our AKI video at Mega King Burgers if you're craving more details. A rare disease on the differential is autosomal dominant polycystic kidney disease, symbolized here by that kidney shaped bunch of cystic balloons. Unlike autosomal recessive polycystic kidney disease, which is typically diagnosed in childhood, autosomal dominant polycystic kidney disease presents in adulthood, usually by the fourth decade. Ultimately, the proliferation of renal cysts results in hypertension, chronic tubulointerstitial disease, and CKD. And finally, if they go on long enough without treatment, both prerenal AKI and postrenal AKI, the causes of which are numerous, can progress to CKD. Chronic prerenal disease can be seen with ongoing heart failure or cirrhosis, for example. Chronic third spacing and decreased intravascular volume leads to decreased renal perfusion, which means the kidney is susceptible to intrinsic injury like acute tubular necrosis. Chronic postrenal obstruction due to prostatic disease or a mass lesion in the pelvis, for example, will also progress to intrinsic disease over time, characterized by tubulointerstitial fibrosis. For all the pre and postrenal deets, I implore you once again to head on over to our AKI sketch. Get your Jurassic Park toys while the supplies last. Alright, time to look at some objective findings. Starting with vital signs. Hypertension is present in the vast majority of patients with CKD. The mechanism is complex and likely related to increased sodium retention. Increased renin-angiotensin-aldosterone activity likely contributes, especially in the setting of chronic renal ischemia. And remember the whole complicating factor that hypertension can actually contribute to the development of kidney disease in the first place. It's kind of like a dinosaur or the egg situation going on here, you know what I mean? Remember that whole volume overload thing we described earlier? On physical exam, look for dependent edema, like in the lower extremities, and crackles on the lung exam due to pulmonary edema. Also in the physical exam, be on the lookout for classic signs of uremia. Listen carefully on the cardiovascular exam for a pericardial friction rub, which could suggest uremic pericarditis. On the neuro exam, most uremic patients will exhibit weakness and unsteadiness. Tremor, myoclonus, and asterixis are common with uremia as well. Asterixis, or should we say asterarchaeopteryxis, is that classic flapping tremor of the hands elicited when the wrists are dorsiflexed. It's seen in many forms of toxic metabolic encephalopathy. Boy, I'm hungry. Let's get some labs. Unsurprisingly, you'll see an elevated BUN and an elevated creatinine, symbolized by this bun bag and raised creatinine credit card. Remember that decreased eGFR estimated by that creatinine is one of the hallmarks of CKD. And how about we wet our whistle with some elevated electrolytes? Hyperkalemia worsens as the kidney failure progresses and tends to develop in the setting of oliguria. Hyperphosphatemia, as we mentioned earlier, rises due to decreased filtration and increased bone resorption in the setting of CKD bone mineral disease. Decreased magnesium excretion in the urine leads to hypermagnesemia. Moving down to the lower shelf, we have hypocalcemia, resulting from decreased vitamin D production, and hyperphosphatemia, causing serum binding. And finally, the lemonade, our symbol for metabolic acidosis. This develops from retention of hydrogen ions and impaired bicarbonate regeneration. Look for a low bicarbonate on that BMP. Well, we've got our snacks and drinks. Now let's check out some science. Bone mineral disease and CKD can get complicated, so let's break it down. Ha! Break it down like bone. Get it? No? I need friends. Anyway, hypocalcemia and hyperphosphatemia stimulate the parathyroid gland to increase the release of parathyroid hormone, or PTH. This is also called secondary hyperparathyroidism. Look for an increased PTH, which promotes bone resorption in an effort to raise the serum calcium. This leads to a spectrum of bone disease collectively called CKD mineral and bone disorder. It's made up of osteitis fibrosis cystica, osteomalacia, and adynamic bone disease. Okay, while this guy freaks out over his broken fossil, let's move along to the next exhibit. In the setting of CKD, a normocytic normochromic anemia is a very common finding. It's due to reduced erythropoietin production by the dysfunctioning kidney. Just think of this broken kidney shaped flask being drained of all those wonderful RBCs. That falling abacus, by the way, is our recurring symbol for decreased hemoglobin on the HNH. Lipoprotein abnormalities can also be seen in CKD. Hypertriglyceridemia is especially common due to an increased rate of production of triglycerides and a lower rate of catabolism. All your CKD patients should get a screening lipid panel, and that includes total, LDL, and HDL cholesterol, as well as triglycerides. All right, time for the fun part, the urinalysis. This can help us determine the underlying etiology of the CKD. Looks like the janitorial department is on their lunch break, so in the meantime, let's carefully walk through the findings for the most prominent etiologies of CKD. In the setting of diabetic nephropathy, you might measure overt proteinuria on a dipstick. But remember that this will only be evident in the setting of advanced diseases. Moderately increased albuminuria, which defines the onset of early diabetic kidney disease, will not show up on that dipstick. For that, you'll need to measure a spot urine albumin to creatinine ratio. More on that in a bit, but in the meantime, check out these meaty plastic dinosaur legs in the puddle by the Diaswedes machine, which we're going to use to represent proteinuria. If the damage gets bad enough, proteinuria can even reach nephrotic ranges. Renal amyloidosis may present with edema and profound proteinuria from the nephrotic syndrome, hence the meaty protein leg near the chainmail purse lady. The same goes for AL amyloidosis and light chain deposition disease seen in the setting of multiple myeloma. One little pearl to keep in mind is that multiple myeloma is also associated with light chain cast nephropathy, which is light chains only, no nephrotic syndrome here. These light chains don't get picked up on the dipstick, so you have to get a urine protein electrophoresis to see them instead. But more on that over in our plasma cell dyscrasia sketch. If you see white blood cells and white blood cell casts, think about an ongoing chronic interstitial nephritis, which is why we place these white dino eggs under that inflamed, kidney-shaped cup of coffee. An ongoing chronic glomerulonephritis will likely exhibit an active urinary sediment. This will show RBC casts symbolized by these lined-up red eggs, as well as dysmorphic RBCs illustrated by these broken red shells. Proteinuria on a dipstick is common as well, so we threw in a dino leg for good measure. Polycystic kidney disease, you will eventually be able to measure proteinuria and heme on a dipstick. The sediment might show red blood cells, which is a sign of hematuria due to bleeding into cysts. We've talked about proteinuria, but that was on the dipstick. Let's quantify that proteinuria. The simplest tests are the spot urine protein to creatinine ratio and the spot urine albumin to creatinine ratio, depicted over at the ticket counter. The meaty protein leg over the credit card sign represents the urine protein over the creatinine. At the same time, the album over the credit card sign represents the urine albumin over the creatinine. Spot tests refer to sampling a single untimed urine specimen. Specific urine protein and urine albumin tests detect smaller amounts of proteinuria than the urinalysis dipstick, so they allow for earlier diagnosis and assessment of chronic kidney disease from diabetes, hypertension, and chronic glomerular disease. These tests also help us estimate the daily protein excretion, which is technically more accurately measured by a 24-hour urine protein collection, but this is a super cumbersome test for patients. Lastly, these measurements are also used for CKD staging. More on that in just a second. In addition to labs, your workup should include a renal ultrasound to look for chronic obstruction and anatomic abnormalities. Incidentally, you may notice an increased cortical echogenicity in small kidneys, which is characteristic of chronic kidney disease in general. Okay, before we get all excited and dive into management, let's review the definition of CKD and go over staging. CKD is characterized by an eGFR that drops below 60 or objective findings of kidney damage. Either must be present for at least 3 months. So to meet the definition of CKD, make sure the patient's lab or clinical abnormalities are persistent. This can be done by repeating testing or looking back at prior labs if available. Once you've determined that the patient has had abnormalities for the required 3 months, We need to stage the CKD. You likely won't be asked to stage CKD on an exam or be required to remember the exact ranges, but it's good to remember that there are two components that go into quantifying the severity of CKD: the GFR and albumin to creatinine ratio. So here we are at the GFR coffee machine, which features another one of those albums over a credit card, our recurring symbol for the albumin to creatinine ratio. These colorful buttons are actually what you'd see on the official CKD staging pictogram, with the red meaning more serious disease and more adverse outcomes. Notice too that we've arranged the GFR as the y-axis and the albumin to creatinine ratio as the x-axis. Okay, let's zoom in on the colorful coffee machine buttons to illustrate our point. A few things to note. The 6 rows represent stages 1 through 6, with increasing stages as the GFR drops. Each column is a different severity level, with increasing severity as the albuminuria level increases, the worst being greater than 300 milligrams albumin per gram creatinine. The combination of these two factors can help predict the risk of adverse outcomes, green being low risk and yellow being moderate and red being high. Check out that row at the very top, and you can see why albuminuria is important to quantify. Increasing albuminuria is associated with worse outcomes, even without severe reductions in the GFR. So if we step back, remember that the 6 rows of buttons represent GFR stages 1 through 6, 6 being the worst, and the columns represent the increasing severity from increasing albumin to creatinine ratio. Okay, if history and initial testing aren't suggestive of an obvious etiology, you might need to proceed to a kidney biopsy for definitive diagnosis. Just look at this kid over here, just ready to grab a chunk of the kidney. This should only be performed if it's going to change management. In long-standing CKD, for example, those with small, shrunken kidneys on ultrasound, the biopsy will likely only show chronic changes, like mostly scarring, which is nonspecific and won't help you diagnose the underlying cause. We'll detail specific findings and workup as we go through the differential. So let's get to it. But first, let's summarize a typical patient with advanced CKD with a sample assessment statement. Dr. Sattler is a 59-year-old woman with type 2 diabetes for 15 years and hypertension for 20 years, who presents with pruritus, lethargy, nausea, and lower extremity edema. Her blood pressure is 170 over 110. Her hemoglobin A1C is 8.5. The physical exam revealed 2+ lower extremity edema and excoriations of the skin. Her labs are notable for potassium of 6.2, a BUN of 150, creatinine of 3, calcium of 7.1, phosphate of 10.6, parathyroid hormone of 780, and a hemoglobin of 8.7. Urinalysis shows 1+ protein with a spot urine albumin to creatinine ratio of 400 milligrams per gram. Estimated GFR is 17 mils per minute per 1.73 meters squared. Ultrasound shows increased renal echogenicity bilaterally. Laboratory and imaging findings are consistent with stage 4, A3, chronic kidney disease, complicated by uremia and hyperparathyroidism. Okay, now that we've covered the presentation, workup, and differential diagnosis for CKD, let's get to the management. The word treats under history is here to remind you to treat the underlying disease, which will help preserve residual kidney function, especially important when the CKD is identified early. In CKD secondary to diabetes, glycemic control is crucial for preventing further kidney injury and even improving proteinuria. So drop that box of candy and control your sugars, my friend. Blood pressure control is another really important issue. In CKD with proteinuria, choose an ACE inhibitor or an ARB as your first med. Hence the ACE towel we've drawn in above yet another one of those meaty dino legs. ACE inhibitors and ARBs are proven to be renoprotective and actually reduce proteinuria. Additionally, intensive blood pressure control in proteinuric CKD patients has been shown to reduce the risk of progression to end-stage renal disease. The optimal goal is less than 130 over 80. There's less convincing data regarding blood pressure control in non-proteinuric CKD. It's not been shown to reduce the progression to end-stage disease, but some data suggests that intensive blood pressure control might reduce mortality in these patients nonetheless. If there's no proteinuria, any of your standard first-line blood pressure meds will do. Just an FYI, in the setting of bilateral renal artery stenosis, represented yet again by those two purses with red straps, administration of an ACE inhibitor or an ARB might actually cause an acute rise in the serum creatinine. Hence the raised credit card held by mom over here. The creatinine rises because these agents dilate the efferent arteriole. Not good for a patient with bilateral stenosis of the afferent. Constriction of that efferent arteriole is crucial for maintaining pressure in the glomerulus, which preserves the GFR. Nevertheless, many of these bilateral renal artery stenosis patients can actually tolerate ACE inhibitors or ARBs despite a small increase in the creatinine due to reduced GFR, but you just have to monitor them closely for full-blown AKI. Okay, next let's talk about diet. To counteract the retention of electrolytes, a low-phosphate diet is recommended. Additionally, decreased dietary potassium is recommended, usually for patients with a GFR that's less than 30. And how about all those salty peanuts? Patients with CKD who have hypertension, volume overload, or increased protein excretion should reduce their sodium intake to less than 2 grams per day. Remember how salt intake affects that serum osmolality balance? Intake of more sodium is balanced by retention of more volume, and volume is bad. Patients with CKD and signs of volume overload, such as edema, usually respond to a loop diuretic and sodium restriction. This is especially helpful when managing a CKD patient who has both edema and hypertension. Loops will treat both. Thiazides are actually not very helpful as monotherapy when the GFR falls below 20, but you might still add them to loops in the setting of refractory edema. CKD is actually an independent risk factor for the development of coronary artery disease, more severe coronary artery disease, and death from coronary artery disease. In fact, in most patients, the risk of death from cardiovascular disease is higher than the risk of progressing to end-stage renal disease requiring dialysis. So make sure you check a lipid panel and start a statin if needed. Make sure to counsel all your patients on smoking cessation. Next, treat metabolic acidosis with bicarbonate supplementation to maintain serum bicarb in a normal range of 23 to 29. A sprinkle of bicarb from that bicarb box will soak that acid puddle right up. Side note, bicarbonate administration is less effective in the setting of ketoacidosis or lactic acidosis. As we discussed earlier, CKD can cause a normochromic and normocytic anemia due to the loss of renal erythropoietin production. Anemia needs to be treated to maintain a hemoglobin of about 10 grams per deciliter, hence the 10 formed by these flasks. Exogenous EPO, which is a synthetic erythropoietin, can raise the hemoglobin and improve anemia. But prior to jumping to EPO, make sure to work the patient up for non-renal causes of anemia like GI bleeding or iron deficiency. The big side effects of EPO are worsening hypertension, headaches, flu symptoms, and winning the Tour de France. In addition, EPO can precipitate a microcytic hypochromic anemia from iron deficiency, since you need lots of iron to make new red blood cells. So check the patient's iron stores while they're on EPO and provide iron supplementation. Remember how we talked about that complicated bone mineral disease? The common lab derangements were hypocalcemia, hyperphosphatemia, and elevated PTH. Now, how do we go about treating it? First, we use phosphate binders to reduce hyperphosphatemia. Tupperware will do just fine. These medications bind dietary phosphate in the gut and prevent absorption. And don't forget to encourage dietary phosphate restriction. Vitamin D deficiency is a very common finding in CKD patients, and it's generally treated the same as deficiency in the general population. Though the evidence is not well established, some data shows that vitamin D replacement normalizes serum 25-OH vitamin D levels and modestly decreases the PTH levels. Good riddance. Now, do not give vitamin D to patients with an elevated serum phosphate level or elevated corrected serum calcium level. Alrighty, one last therapy to cover before we move on to renal replacement therapy. Remember all that potential platelet dysfunction and bleeding in the setting of uremia? Well, DDAVP is your go-to adjunct renal replacement therapy for treating uremic bleeding. It's rapid, it's generally non-toxic, and it's represented by this DDAVP ATV riding into the scene. It works by increasing the release of von Willebrand factor multimers from the endothelial cells. That ought to help those platelets stick together. Speaking of, looks like he found another piece of those broken Stegosaurus plates. And for the grand finale, let's talk about renal replacement therapy. Renal replacement therapy, or RRT, refers to replacing the normal blood filtering function of the kidneys in the setting of renal insufficiency. That means AKI or CKD, by the way. It's also used to filter the blood in the setting of certain toxic ingestions. RRT is actually a more general term than dialysis. It encompasses intermittent hemodialysis, peritoneal dialysis, and continuous renal replacement therapy, as well as some other hybrid technologies. There are certain times when you choose one over the other. For example, continuous RRT in hepatic failure or acute brain injury. But we'll just stick with the general term RRT for this sketch. Hemodialysis is the most common kind of RRT. With this method, patients are hooked up to a dialysis machine. Blood moves through the machine and is filtered through a semi-permeable membrane via counter-current exchange, and then it returns to the body. Nephrologists pick specific dialysate solutions to correct electrolyte abnormalities. You see those capitalized letters on the side of this dialyzer floor cleaner? They spell out AEIOU. That's acidosis, electrolytes, ingestions and intoxication, overload, and severe uremia. Renal failure can lead to metabolic acidosis through impaired acid excretion and bicarbonate regeneration. The cutoff is usually a pH of less than 7.1. In the setting of AKI, a trial sodium bicarbonate infusion while attempting to treat the underlying cause is reasonable, though only in patients who are not volume overloaded. Bicarbonate is a major salt load and will worsen volume overload. Now, if the acidosis gets worse or they're volume overloaded, you can go straight to RRT. The E stands for electrolyte derangements, with hyperkalemia being the scariest. See our dedicated hyperkalemia videos for more information on management of that. If potassium fails to improve after medical therapy, you're going to have to proceed to dialysis. The same goes for hyponatremia, metabolic acidosis, hyper or hypocalcemia, and hyperphosphatemia that's refractory to medical therapy. The I stands for ingestions and intoxication, which doesn't really apply to renal failure directly. The major ingestions that require RRT are methanol, ethylene glycol, lithium, and salicylates. Out of these, only ethylene glycol causes AKI, which we'll address in our upcoming AKI sketch. The O stands for overload. Volume overload, that is. If the patient doesn't respond to loop diuretics, go ahead and start RRT. Last but not least is U for severe uremia. RRT is used to treat CKD patients with encephalopathy, pericarditis, neuropathy, or decline in mental status secondary to uremia. These AEIOU indications are more common issues in the setting of AKI. CKD patients, on the other hand, are often diagnosed before they develop severe manifestations that require dialysis, though these AEIOU problems can pop up in patients with CKD who have gone undiagnosed for a prolonged period of time. Once CKD progresses to stage 5, which is the most severe stage, we call this end-stage renal disease. Nephrologists start to discuss RRT about a year before anticipated need. Generally speaking, RRT is started when the estimated GFR is about 5 or less, even if the patient has no signs or symptoms of end-stage renal disease. Ultimately, the patient might qualify for a kidney transplant. Transplanted patients have improved mortality and report an increased quality of life. In terms of long-term survival, a living related donor is the best source for a transplant. This is followed by living unrelated donor and then cadaveric donor. These patients require lifelong immunosuppression. Usually it's a combination of prednisone, tacrolimus, and mycophenolate. Well, that about sums up our tour. Let's review what we've learned here today. Chronic kidney disease, or CKD, by definition is a reduced GFR of less than 60 or evidence of objective signs of kidney damage, persisting for at least 3 months. Early CKD will usually be asymptomatic. Patients with CKD are prone to episodes of volume overload, manifesting as dyspnea and leg swelling. When the GFR dips below 15, signs of uremia can develop, including fatigue, nausea, vomiting, pruritus, signs of uremic encephalopathy, uremic mono or polyneuropathy, and of course be on the lookout for uremic pericarditis and impaired platelet function. There are a whole number of things that can cause CKD. The most common in the United States is diabetic nephropathy. Hypertension is also really common. Then there's bilateral renal artery stenosis due to atherosclerosis, or less commonly, fibromuscular dysplasia. You've got chronic glomerulonephritis, amyloidosis, chronic interstitial nephritis, autosomal dominant polycystic kidney disease, and finally, any prerenal or postrenal disorder. If it's allowed to sit there for long enough, can progress to intrinsic kidney injury and eventually CKD. Objective findings of CKD include hypertension, as well as lower extremity edema and pulmonary edema in the setting of volume overload. A pericardial friction rub may be a sign of uremic pericarditis, while uremic encephalopathy can present with weakness, unsteadiness, tremor, myoclonus, and asterixis. Labs will show an elevated BUN and creatinine. Other characteristic electrolyte disturbances include hyperkalemia, hyperphosphatemia, and hypermagnesemia, as well as hypocalcemia due to decreased vitamin D production and serum binding by phosphate. Metabolic acidosis can develop from retention of hydrogen ions and impaired bicarbonate regeneration, so look for a low bicarb on your BMP. Elevated PTH is a sign of secondary hyperparathyroidism. A normocytic normochromic anemia is caused by decreased EPO production by the kidney. And how about that hypertriceratops? Hypertriglyceridemia. Your analysis will vary depending on the underlying cause of CKD. Diabetic nephropathy will show overt proteinuria on dipstick if severe, but it's associated with only moderate increased albuminuria early in the course of disease, which you cannot see on dipstick. You can conveniently measure this with a spot urine albumin to creatinine ratio. The same goes for amyloidosis or light chain deposition disease related to multiple myeloma. Moderately increased albuminuria in early disease, overt proteinuria detectable on dipstick with more severe disease. They can even present with nephrotic level proteinuria. Chronic interstitial nephritis will show WBCs and WBC casts on urinalysis, while chronic glomerulonephritis classically shows RBC casts, dysmorphic RBCs, and proteinuria. Autosomal dominant polycystic kidney disease is associated with proteinuria and hematuria. And just reiterating here, you can quantitate proteinuria with a spot urine protein to creatinine and urine albumin to creatinine, both of which can detect lower levels of proteinuria compared to dipstick, and therefore detect and monitor kidney disease earlier in its course. Renal ultrasound is used to evaluate for obstruction or anatomic abnormalities. CKD kidneys classically show up as small in size and with increased cortical echogenicity. We stage CKD based on GFR and albumin to creatinine ratios. And finally, go ahead and get a renal biopsy, but only if the etiology is still uncertain and this is likely to change your management. Management of CKD starts with treating the underlying causes. Got diabetes? Control the blood sugar. Got hypertension? Treat the blood pressure. Use ACE inhibitors or ARBs in patients with CKD, proteinuria, and hypertension. 130 over 80 is the goal. Patients with CKD should consume a low phosphate diet, low potassium as well if the GFR is less than 30, and low sodium if your patient has hypertension, volume overload, or increased protein excretion. Loop diuretics are used to treat edema, and hey, if you have hypertension, hey, it'll treat both. And don't forget about that statin and smoking cessation. CAD is the #1 cause of death in patients with CKD. Additional treatments are erythropoietin, sodium bicarb for metabolic acidosis, and phosphate binders. Just keep a lid on it. We start renal replacement therapy for a number of indications, best remembered using the mnemonic AEIOU. These include metabolic acidosis, which is not amenable to bicarb therapy, refractory electrolyte disturbances, ingestions and intoxication, refractory volume overload, and symptoms of severe uremia. Finally, RRT is used at end stages of renal disease when the GFR is less than 5, even if the patient has no signs or symptoms of renal failure. And don't forget, kidney transplant is the ideal form of RRT. Alrighty, that about sums it up for me. It's gift shop time, and those Diet Sweeties candies have got my name all over them.